our panelists tonight. We're really, really grateful to have them with us. First off, someone I was lucky to meet at one of these big conferences, very busy guy, really excited that he's spending the time with us today. Dr. Joshua Brody, who is the director of the Lymphoma Immunotherapy Program at the Tisch Cancer Institute at Mount Sinai in New York. So Dr. Brody, if you could introduce yourself and also maybe just share a little bit about what drew you to becoming a specialist in lymphoma and anything else you'd like patients and care partners to know about you.
Definitely. Hi, thank you so much. This is a great opportunity. It's really nice to try to reach out to talk to human beings as directly as we can. So those are good questions. Yep, I run the Lymphoma Immunotherapy Program here at the Icahn School of Medicine at Mount Sinai here in New York. If you haven't been to New York, you should come check it out. It's lovely. We have a new pizza place. It's real good. And here at Mount Sinai, we are very lucky to be an NCI designated cancer center where one of our missions is beyond just patient care is try to get the next generation of patient care, which is, as you said, part of developing clinical trials and helping to get patients access to newer, hopefully better, hopefully safer therapies. What got me into being a lymphoma doc? It's a couple of years ago now. There were a few things about it. I was committed to becoming a cancer doctor from the time I was 6 years old, but that's, I guess, a longer story. And then as that developed, the plan was for me to become a cancer doctor that developed new immunotherapies for cancer. And so a big part of becoming a lymphoma doc was that we're just very lucky to have probably the best precedent of immunotherapies helping patients with lymphomas. And folks here tonight are going to speak to some of those. And really even what you call the standard old chemotherapy, it's not that old because rituximab is an immunotherapy that is part of that old chemotherapy. And when I started doing this, rituximab was not even a therapy. So immunotherapy has a great precedent, using the patient's own immune system to help fight their cancer has a great precedent in lymphoma. And that is part of what got me interested in lymphoma. And the other part was just that I was doing my training at Stanford in California, and it's a very well-known lymphoma place. So it was a great opportunity to become hopefully great at the thing that they are great at. So there were a few things converging to get me to become a lymphoma doctor, and now I've been doing it for a while.
And just want to say, really, grateful that we have people like you who've been in this for so long and are so dedicated to helping to figure out what is effective and also what will help with the quality of life. So really excited to get the discussion going with you, Dr. Brody. Thank you for sharing. Next up, we have Chrissy, who is a nurse navigator with the Leukemia and Lymphoma Society's Clinical Trial Support Center. And Chrissy, we know that you are on the phone all the time helping patients and their family members. Please share a little bit more about yourself and what drew you to becoming a nurse.
Thanks, Stephanie. So my name is Chrissy Kuss. I work in the Clinical Trial Support Center at the Leukemia and Lymphoma Society. I became a nurse about 12 years ago and started my career early, kind of moving around the units in the hospital every 4 to 6 weeks. And I spent the last 5 to 7 years helping patients pretty specifically with CAR T-cell therapy and lymphoma. The last 2.5 years, I've been with the Leukemia and Lymphoma Society and the Clinical Trial Support Center. We're a team of nurses who help patients and their families explore clinical trial options, learn about their treatment options, and then navigate that whole journey.
Thank you, Chrissy. Now I'm also really excited to introduce our final panelist tonight, Dr. Robyn Stacey Humphreys, who has such an incredible story. Someone I've gotten to know, feel very lucky to know you. You have such an incredible perspective as someone who is a physician who then also got your own diagnosis, and not just once, right, but going through treatment 3 times. So Robyn, can you share a little bit about yourself? We'll talk about your diagnosis in a moment, but share about you, Robyn, outside of the cancer context, because as we all know, we are so much more than a diagnosis.
Well, thanks so much. First of all, hats off to Dr. Brody. We're very lucky to have him on this panel. Secondly, sort of like Dr. Brody, I actually wanted to be a doctor from the time I was 5 and 6 years old. So fast forward, I go into medical school and residency in radiology, and my subspecialty ends up being a lot of cancer focus. I did something called body imaging, PET CT, and also do mammography. And I used to diagnose cancers. I used to do biopsies. I still do, actually. And this was my field of expertise. And ironically, then I was diagnosed with lymphoma out of the blue in my late 40s, very much of a shock. So to be on both sides of it, where I'd been taking care of patients, and actually both my parents passed away from cancer, different kinds. And then of course I developed myself. And then navigating the cancer world as both a patient with the background of being a physician has been unusual. And that's one of the reasons I'm thankful to be here. I feel like one of my missions is to try to give back, to try to bridge the gap between doctors sometimes and patients, so that they can learn to talk to each other better, and so that patients can learn to advocate for themselves and doctors can perhaps understand where they're coming from. So I'm very thankful to be here, and thanks so much for inviting me.
Yeah, definitely thank you for being here and for offering that perspective that is very unique. Clearly, we have two physicians on tonight who really care about the patient perspective, and let's get this going, right? I mean, this is a personal topic for me as well. DLBCL is all over my medical charts. I was 31 when I was diagnosed, and so just like you, Robyn, there's that shock, and I remember trying to understand, what do these letters mean? Lots of alphabet soup coming at you when you get diagnosed with cancer of any kind. So first, let's start, Dr. Brody. What, in as human terms as possible, is diffuse large B cell, DLBCL, and maybe are there some common first red flags or symptoms?
First, Stephanie, I got to apologize for the alphabet soup. Yeah, that is a thing that we do. We just making up code names with lots of letters in them just to be confusing. It's not just to be confusing. It's also because there is so much we've learned in these decades and decades that we make subsets of subsets, and then we need more alphabet soup to describe all the subsets. PMBCL, DLBCL, non-GC. Yeah, it's letters on top of letters, but that's okay. Anything that we can say in medicine or science, we should be able to say it in English as well. So in regular English, lymphoma is a cancer of lymph cells. What are lymph cells? So this is, real simple. You think about breast cancer, cancer of breast cells, prostate cancer, cancer of prostate cells. It's a healthy cell that becomes a cancer. So what are lymphocytes? Lymphocytes are a certain type of blood cell. They are specifically blood cells that may live in your lymph nodes. When you say swollen glands because you had a cold or a sore throat or something, those glands we're talking about are usually lymph nodes. And lymph nodes are all around your body, your neck, under your arms, inside of your abdomen, everywhere. So that's the first tricky thing, because when you think breast cancer, prostate cancer, you think, oh, I know where the prostate is, and so that makes sense. Lymphoma comes from lymphocytes, which mostly live in lymph nodes, so they could be anywhere in the body. So when we say what are the sort of common presenting symptoms of lymphoma, yeah, it depends on which lymph node area had a cell become cancerous. But still, amongst all of those possibilities, swollen lymph node in the neck, swollen lymph node under the arm, we still say that the most common presentation is just a painless swollen lymph node. And where that is, right, can be very variable, literally anywhere in the body. And then there are even subsets of lymphomas that don't even show up in a lymph node per se. Sometimes we talk about this primary mediastinal B-cell lymphoma. They are lymph nodes there, but they're not in the common lymph node spots we think of, the neck, the underarms, and so forth. They just show up in the middle of the chest, the mediastinum. So nonetheless, the most common presenting symptom is just a painless lymph node. Now, this is a scary thing to say on a webcast, because everyone says, oh my God, I had a little lump there. I need to get that. Okay, first of all, most of the lumps you get because you had a sore throat are not a painless lymph node. Usually they are painful, a tender lymph node. So already if you have a tender lymph node, that's a little less likely to be lymphoma than just inflammation, result of a cold, a sore throat, whatever. Again, not every lymph node that gets a little bit swollen needs to be emergently evaluated. Otherwise, every person would have a swollen lymph node at some time or another. The first thing we have to pour on this is a bit of common sense. You have a lymph node that's a bit swollen for a few days, okay, you can watch it for a few more days, and if things start to recover on their own, probably you don't need to go and get that swollen lymph node evaluated. But yes, lymph nodes that are swelling and usually painless, and getting worse over weeks and weeks and weeks, yes, those need to get evaluated. Those are the most common presenting symptom of diffuse large B-cell lymphoma, which is the most common, or we say the highest incidence type of lymphoma.
Thank you for that. And I really appreciate you sharing the differences, right? Because people do get really worried. I have that, there's swollen lymph nodes, and the differentiation between what is more common, place versus when you need to maybe get something checked out. So what I heard was if it's weeks and weeks, and usually it's painless swelling. So thank you, Dr. Brody. And Robyn, again, yeah, you went through this yourself. And so it'd be great to hear from you. What was it for you that was a red flag that led to the diagnosis? And share a little bit about getting that diagnosis.
adding on to what Dr. Brody said, I had a swollen lymph node, but it was an unusual location. Given my field of cancer detection, I actually had a lymph node in what's called your supraclavicular region, which is, you never have normal lymph nodes there. When you have a cold, those don't swell up. Usually when you have a lymph node above your collarbone there, a lot of times it can be a symptom of lung cancer, gastric cancer, ovarian cancer, or even breast cancer. But I felt a lymph node literally while I was watching TV, and I knew it was bad. There's just, it's never good. So my process for diagnosis went very fast. I ended up with a CT the next day, which I looked at, and I found out I had lymphoma, because not only did I have this, I had lymph nodes all the way up and down my neck, which you couldn't feel. And I'm not a big person. They were all very small. They were just too many of them. And I actually had some lymph nodes behind my nose, and then something called Waldeyer's ring. And I thought I'd had allergies. I was congested, and that actually was lymphoma. So somewhat of, not totally unusual presentation, but everything went really fast. It was a shock. I mean, I really had no symptoms besides that. I was working 60 hours a week as a mother of 3. I ran every day. I ate well. And before I knew it, I had a CT scan, a PET scan, a port put in, and immediately I started on R-CHOP, which is the standard therapy. And it was initially very successful for me, but we digress. And then I go on to when it didn't work later, but at first it was very successful. I did 6 rounds of R-CHOP. And as Dr. Brody said, Rituxan changed everything. When I was in medical school, non-hodgkin lymphoma cure rate was very low, only about 30 or 40%. And once you added Rituxan, it's over 70% in a lot of cases. So things have progressed even in the last 10 years, and now with the immunotherapies, things are totally different.
Yeah, I appreciate that. I mean, first, what a strange experience to have essentially self-diagnosed and have to read your own scans and images. But you do that for a living. And so, and I appreciate both of you talking about just how quickly things have changed in the last 10, 15 years, and then even in the last 5 years or so, with immunotherapy. And that's what's exciting to be able to talk about, but also why these programs are so necessary, because it is a lot. And it's great to have people who specialize in this area so that there's a depth of knowledge about all the different options and for whom these options are best for. So Robyn, you mentioned R-CHOP. Let's go there. Let's talk about standard of care before we go into the clinical trial space. Dr. Brody, what has been the standard first-line treatment in DLBCL? We heard Robyn talk about R-CHOP, and we also can cover something that's a more recent approval.
Yeah, so for the past 20 years, maybe there's been a bit of an evolution or change in this just in the past 1 year. But for the past 20 years, absolutely, R-CHOP has been, I would say, the standard of care. It doesn't mean that everyone gets R-CHOP, but most people do, certainly more than 80%, probably more than 90%. Some people may not get R-CHOP maybe because it can be a little tough. So we have patients who are in their 90s and they may get a gentler version of R-CHOP or even slight variations of that. We do have patients in their 90s who still get R-CHOP, but it's not gentle therapy for a 40-year-old like Dr. Stacey Humphries was, and it's definitely not gentle therapy for someone with 2 of those 40-year-olds underneath their belt. So we sometimes give gentler versions, and there's sometimes even more aggressive versions. There's a therapy that, Stefan, you definitely know about, called REPOC, R-E-P-O-C-H. So you can hear it's all the same letters as R-CHOP plus one more letter, the E. And again, it's really just kind of a tougher version of R-CHOP. In some ways, it seems to be better in that it's maybe more effective, but in a big randomized trial comparing the two, there wasn't a clear difference. So we think that maybe REPOC is just good for certain super high risk subsets of patients. And so maybe 5 or 10% of patients, instead of getting R-CHOP, might get that REPOC. And yeah, that has, as Dr. Stacey Humphries said, was a big evolution just from the CHOP of the 90s. And easily added a 10+% increase in the cure rate to standard therapy for these patients with DLBCL. So it's a big deal. Actually, I was very lucky because rituximab sort of came out of Stanford, and IDEC, Biogen, Genentech back in the early 2000s. So it was an exciting time for us to have that big, that sea transformation, a change in era. We now entered the rituximab era of treating patients with DLBCL. So that was exciting to see. And now we're still seeing maybe comparably exciting evolutions to what may be the standard going forward now.
That's amazing. Yeah, and to have all that history and to be front and center when it was all going on, that must have been exciting. And speaking of changes, we have a recent approval that, of course, was in clinical trials and then was approved by the FDA, polatuzumab or Polivy, and R-CHP, which is R-CHOP without the O, for first-line treatment. The question, I think, when these things happen is, how much real-world data is there? And just what are your thoughts about it as another option for people?
Yeah, exactly that R-CHP, Pola R-CHP, we say, is another option. It's not the right answer, but it might be the right answer in the future. We'll see. Yeah, the alphabet soup is tough enough when the words are pronounceable, but once you take the O out of CHOP, now it's R-CHP plus polatuzumab. Harder and harder to pronounce, but maybe more effective. So there's this big trial, Polarix, a randomized trial. Half of the patients got R-CHOP, half of them got Pola R-CHP. And the punchline was that the Pola R-CHP was a bit more effective. Maybe 6% more people stayed in remission for the first couple of years. So it's possible that could, eventually translate to an increased cure rate, but it's not that yet. We need more time to follow those folks and see how they do. But a 6% increase, staying in remission for 2 years, that's not nothing. I mean, if you were one of those 6 out of 100 people, that'd be a big deal for you. The only catch is it's not, for free, in that there is some extra side effects, but not too bad. It's just that the risk of infections during the therapy was moderate, but it was also a bit increased in the Pola R-CHP. Interestingly, it was about a 6% increase on that side as well. So maybe 6% more people staying in remission, maybe 6% more people getting this significant side effect. The side effect lands you in the hospital, so it's not nothing. So a little bit tougher on lymphoma, but a little tougher on patients as well. So is it the right therapy? I wouldn't say it's the right therapy for everybody, but certainly every lymphoma doc is kind of weighing each patient. It's supposed to be individualized, personalized for each patient, and saying, yeah, this patient might, do well because they're younger and healthier and wouldn't, have a high risk of side effects. And this patient, may not do well. A 90-year-old probably wouldn't get Pola R-CHP. Because already R-CHOP is tough therapy for them. And also maybe for the higher risk patients, and maybe certain subsets of the high risk patients might get the most benefit from the Pola R-CHP. So probably in America in the near future, maybe half of patients are going to be getting Pola R-CHP and half of them getting a good old R-CHOP as we go forward.
That's great. Thank you for sharing that, and interesting to hear that sort of, okay, maybe it's half and half, we'll see. And so we'd like to take in one of the patient questions, actually. Wilson A asks, what's the risk of relapse with DLBCL, and what is the leading treatment for those who relapse? So Dr. Brody, I'll move to you again on this question.
Sure. Well, as Dr. Stacey Humphries said, we cure the majority of patients. This is awesome. Not just compared to the 90s, but compared to the 70s when I had relatives that had this disease. So yeah, we cure the majority of patients. That's wonderful, but it's not 100%, and we would like to get it there. So probably today we are curing more than 65% of patients. Kind of depends on which study you look at, because a lot of these studies focus actually on slightly younger, slightly healthier patients. And if you look at everybody, it's probably about 65, maybe a little bit above that, with standard 2023 therapies. But we also see that increasing as well, even over the next few years, from some of the exciting things we're going to talk about. So maybe 35% of patients, about a third of patients could still relapse. And then the standard of care for them, we could talk about it in detail, but in big picture, it actually depends on a few things. But the first thing it depends on is when they relapse. So if patients relapse very quickly, they relapse within the first year after that R-CHOP or whatever they had, the approach is a bit different. The idea there is they just got chemo and it didn't work very well. So really giving something that kills cancer in a different way might be better. And that was tested in a big trial, a couple of big trials, the Transform trial and the Zuma 7 trial. And the punchline of those trials were that for those early relapsers, and it also includes people that didn't get a good remission at all, for those early relapsers, and we say refractory patients, CAR T cells, this very cool immunotherapy we're going to talk more about, and there's some personal experience here to talk about as well. CAR T cells were superior to the old standard. The old standard was basically more chemo, and actually a lot of chemo. which was tough therapy. So those trials are actually, they were both showing that CAR T were better. And if you look, sort of read between the lines, they were also, I would say, safer and better tolerated. So that's kind of a rare win-win, both better and safer. We don't get a lot of those, in new cancer therapies. I kind of mentioned the Pola-R-CHP. It was not really a win-win. It was maybe better, but not safer. This CAR T versus the old standard of just more chemo, it was a real win-win. So for early relapsers and refractory patients, CAR T is the standard of care. It doesn't mean every patient has to get it. There's still some individualization. But for the early relapsers, that's been the big change over the past year and two. That was not the standard of care even a couple of years ago. And then for patients whose disease relapses later, it's even more individualized, but the old standard for younger patients with late relapses was this more chemo and this sort of, we say, mega dose chemo approach called autologous stem cell transplant. Autologous just means you give the stem cells to yourself. It's a little fancy how it works, and we will talk about it, but we just want to distinguish it from this other kind of transplant where you get stem cells from another person. We call that allogeneic stem cell transplant. For people that relapse a little later and they are young and tough enough to tolerate this tough therapy, more chemo and autologous stem cell transplant, that is still the standard. But that doesn't really apply to every patient because, when we did those first studies, it were for people under 60. Then we started doing it for patients under 65. Now we do it for patients under 70. But it's a tough therapy for people who are around the median age of this disease, which is upper 60s and 70s. So it is a standard of care, but a lot of times for those late relapsing patients, they may not be eligible for that approach. So then there's a whole bunch of other, thankfully nowadays, maybe more targeted options that we'll talk about as well.
Wonderful. Thank you, Dr. Brody. Well then, Robyn, with your patient story, you ended up, you had a good response to R-CHOP in the beginning, as you mentioned. It didn't stay that way. We'd love to understand more of what happened. How far along were you until you realized something's not right again?
Well, I was actually in complete remission for 4 years. And my relapse happened when, again, I actually felt a lymph node in my neck, which I knew wasn't supposed to be there. And as Dr. Brody said, the standard of care at that point, which was in 2015, was to go ahead and get an autologous stem cell transplant. First, they give you something called salvage chemotherapy. RICE is what I received, and there's more initials. It's a very rough chemotherapy. And then I also got something called intrathecal chemotherapy to prevent the lymphoma from coming back in my brain. And then I was confirmed to be in remission, and then they went ahead and did the stem cell transplant. They'd already harvested stem cells, and they ablate your bone marrow using the strongest chemo possible, and then they give you your marrow back, and it's really a rescue. I mean, you have no cells left, and they give you your marrow, and then you have to wait for your marrow to come back. And like many of the people who go through this, the biggest risk is infection, and of course, I actually got something called septic shock, where you're in the intensive care unit, very, very sick. On medicines, pressors, et cetera. So when I survived that, in my case, it was decided among several institutions, because my case was slightly unusual and everyone does try to do patient-centered care. I ended up getting radiation, which was really horrible. So, 2 thumbs down, don't recommend, but I'm still here. And so that was my second treatment, but I was very, very sick. I couldn't eat solid food. I dropped from a BMI of 22 down to a BMI of about 15 or 14. It was quite difficult. And then, I was actually then trying to work. So that was my second experience, and I just it wasn't great. But you do what you have to do just to survive. And I did get great care. So my doctors were fantastic. It just had some complications. That was
absolutely.
my second relapse.
Right.
So first relapse,
right.
I should say.
Yeah, right. First relapse, and you still, even after having gone through so much intensive treatment, it still wasn't done, right?
And so then
what happened?
I was remission for 9 months after the autologous stem cell, and then actually the CAR T, the lymphoma came back. At this time, it actually sort of came back even more aggressively, because not only was it in my neck, it was underneath my armpit, in my groin. That had never occurred before. And at that point, they found out I had no match for an allogeneic transplant, and no one was even close. And the doctors were very shocked about that. But I had already decided I did not want to go through that again. And I had done some research online at www.clinicaltrials.gov, and I did this on my own. And we had started researching other options, and I had heard, things about these T cell therapies. They had talked about killer T cells, CAR T. It had actually been in the news in 2015, or 16. So I started looking into that. And that's how I actually ended up going into a clinical trial. And I'm very, very grateful I did. It was a phase 2 trial. It was definitely a leap of faith, but I just had a feeling it was the right thing for me. And I was an excellent candidate because I was in really, really good health, except for the fact I had lymphoma. So for a clinical trial, this is perfect because I had no comorbidities, and that way the doctors could actually figure out, is this going to really work, or was there something else that would interfere with the procedure?
Thank you, Robyn. I super appreciate you laying all of that out. And you mentioned clinicaltrials.gov. It's a great resource. It is not the easiest to navigate, especially for the lay person like me at home. And so that is where the LLS's Clinical Trial Support Center is so wonderful, resources like that to help people really navigate what's out there. And this is a great segue too, Robyn, and I'll ask a little bit more about your experience in just a bit on clinical trials. But when we talk about clinical trials, the research is happening to hopefully help provide more options for people, right? And the two buckets that I know a lot of patients have talked to me about would be efficacy, or how successful it is at saving or increasing your life, span or whatever, and safety, which really is just quality of life, side effects. And, that's a big part of the conversation when you talk to patients. Yes, I want to live longer, but also how is my quality of life going to look? So these are the different things that are being tested, and doses and all these kinds of things. So Dr. Brody, you've been involved with, led so many clinical trials. Can you help us explain again in human terms, what is a clinical trial?
I mean, we should take Dr. Stacey Humphrey's example of this. Robyn got that in 2016. There was no FDA approved CAR T cells in 2016. They got approved in 2017. So what are they? They're lifesavers. I mean, because look, here she is today, beautiful and alive. And I think we're not supposed to say this out loud, but I think we're kind of quietly allowed to say probably cured of lymphoma here, now almost 7 years later. So what are they? That's what they are. They are an opportunity to get access to a thing that is not yet FDA approved, or sometimes the things are FDA approved, but this is a newer version or a better version or a combination. So the things may or may not be FDA approved in their own right. But in Robyn's case, that was the only way to get access to CAR T cells, which now, all these years later, we, after the fact, realize are in many ways superior to the autologous transplant and the rice and all that stuff that she got. Not in every setting, but in some setting, blatantly superior. So, this is just like a preview of a future medicine. And again, we don't want to oversell it because not every clinical trial is successful, although in lymphoma, we've been lucky to have more successful clinical trials, more rapid progress than any other cancer. Lymphoma, 5th most common cancer in America. That's pretty common, but not as cancer as other ones like breast cancer. But still, we have more medicines for lymphoma because so many of these trials have been successful. So yeah, what is a clinical trial? It is something that is given not as a standard of care, but only with sort of careful FDA oversight, because we can't ever do a trial unless we get all of these things blessed by many different groups, but by institutional ethical boards, local ethical boards, and of course by the FDA. So it is a way of getting access to hopefully futuristic medicines, but things that are not yet FDA approved, or not yet FDA approved in that combination or in that specific way. And as you say, that is, the great thing about them. The tough thing about them is what you were hinting at, going to find, which one is where at what time is extremely difficult. Clinicaltrials.gov is the same tool we use, but it's not super user friendly. I mean, you can look at it and you might get the answer, at least it might guide you to who to call. But, really, there is no one, easiest, best way to find out what is the right clinical trial for me. Because even if you go and ask your doctor, they know about some, but it's hard to know about every single trial in America at any given moment, because they change even from month to month. But they are these carefully regulated opportunities to get access to medicines or combinations of medicines that are just not yet FDA approved. Yeah.
Right, lot to wade through. Thank you, Dr. Brody. And let's bring Chrissy in right now. A great time because Chrissy, you're on the phone a lot with patients, their family members, answering questions about clinical trials. We'd love to understand what are the top questions that you're getting and some of the misconceptions also that you're hearing about clinical trials.
One of the biggest misconceptions that I hear from patients almost daily on the phone is that they're worried about participating in a clinical trial because what if they get the placebo part of the trial? And that's a huge, huge misconception with clinical trials because in the United States, placebos are very rarely used in clinical trials. The way that a placebo would be used in a clinical trial would be used in addition to something that is proven to already be effective. Another big misconception about clinical trials is that everything on a clinical trial is free, or that if a patient doesn't have insurance, they can participate in a clinical trial to get a drug for free. And unfortunately, while I wish that that was true, that everything, on a clinical trial is free, it's not. Lastly, the other misconception that I hear quite frequently is that patients think that they can only participate in a clinical trial if they've exhausted all of their treatment options. And that could not be further from the truth. There are clinical trials for patients in every step of their diagnosis, from the time that they're first diagnosed all the way through having failed multiple lines of prior therapy.
Okay, thank you so much, Chrissy, for that. We talked about CAR T a bunch and would like to delve into this a little bit more. We have been getting a lot of patient questions actually on CAR T cell therapy. So both doctors have talked about when it was approved. Robyn, we're going to talk to you shortly about your firsthand experience being one of the first to experience CAR T cell therapy via clinical trial. But Dr. Brody, can you overall give us a general description of CAR T cell therapy? What is it? What does it entail? I think that's a big question people wonder about.
When I describe CAR T cells to my patients, they think I'm kidding. It sounds like science fiction, sounds like teleportation or, light speed travel. And then you have to know, yeah. And maybe it's my own fault because I do kid with my patients sometimes. So that's why they think I'm kidding about this, but it's a real thing. And they think, oh, what decade, when will that be here? No, it's here now. It's already here. It's a real thing. So CAR T cell is a combination of gene therapy and immune therapy. Literally, we take out some of a patient's immune cells, we send them somewhere, either to Santa Monica or a factory somewhere, where they turn them from normal healthy T cells, our own healthy immune T cells, and they insert this new gene called a CAR, chimeric antigen receptor, CAR. So they insert this CAR into the T cells, now we call it CAR T cells, and then they FedEx, I'm exaggerating, but they ship that back to you, and they reinfuse those CAR T cells into the patient. It's not even quite as simple as that. The patients have to usually get some type of, I will say, gentler chemotherapy before the CAR T cells are reinfused. We give that to sort of make room for the new cells to come in. It's a bit of metaphor, but it's conceptually fair. And those CAR T cells, the gene that we put in, the CAR, helps those T cells, those immune cells, to go now traffic to your diffuse large B-cell lymphoma and eliminate it probably more potently than any other single therapy that we've ever developed. Close to some other immunotherapies now, but it's quite amazing. We take out some immune cells, we put a new gene into them, we reinsert those CAR T cells, they go and melt away lymphoma. And they don't do it perfectly, and they don't do it for 100% of people, but they induce remissions in a good majority of people. And depending on the setting, they may cure, it depends on the setting, but maybe 35, 40, maybe even 50%, but we usually say about 40% of patients. But again, it depends on sort of what's happened to that patient before and some other things about the patient. But they, take what used to be an incurable disease, because for Dr. Stacey Humphries, we used to call that an incurable setting. We said, oh, third line diffuse large B-cell lymphoma, that's incurable. And here now we're curing, 40% or more of those patients. So it's miraculous, and it's not science fiction. It's a real thing.
Robyn, you went through this. Let's rewind a little bit first. Just, you are in, you're a physician, so you have, I think, more of a know-how maybe of navigating clinicaltrials.gov or understanding what's in the pipeline. How did you determine that this was what you wanted to do? What was so, you mentioned it was a leap of faith. And, was it you who brought it up? Was it a different doctor who brought it up? And what was the experience like when you actually went through CAR T?
In a nutshell, I decided that I want to do CAR T because I didn't have an allogeneic match, and that would not have gone well. the best. I could have had a haplo match, which is a half match with my son, but I had not done well with the auto stem cell. So I didn't think I was going to do well, or I may not have survived an allogeneic stem cell transplant, and I may not have had a normal life. I wanted to have that quality of life. And the theory of CAR T, I'd read about it in some scientific articles, and I just Googled this. Nobody really told me anything. I just thought this made sense, because right now, the basis of cancer therapy is you either cut it, you burn it, or you poison it. So taking your own immune cells, it's actually, much nicer. It's, lovely as compared to the other ones, even though it has side effects. So when I did the clinical trials, I really didn't have that much of an insight. I just put in my diagnosis, I found out all the trials, and we emailed every single investigator. And that's how I ended up. And the reason I ended up in the trial was it was, quite frankly, the only opening that existed. We even looked in Sweden, we looked all over. I was really ready to sell the house and move wherever. So we were lucky to get one about 9 hours away. So fast forward, I signed up for CAR T. It is brand new. I'm the second person at this hospital, huge hospital, that gets the treatment. When they took my T cells out, then they gave me some, just one chemotherapy agent. I got bendamustine, some people get Flu-Cy, and then had these T cells infused, and they were in like a little 10 cc bag, and the infusion took about 5 minutes, and everyone in the room clapped, and they just left. So it was very anticlimactic. But in my case, they actually started working very quickly. So by the time I came in, I had a lot of lymph nodes here in my armpit. The one in my groin was really hurting. And within 24 hours, they started melting. And within 7 days, basically all my palpable lymph nodes were gone. And I did develop something called a cytokine release syndrome, which is the body's reaction. There's a lot of different side effects, but in my case, it was fever and low blood pressure. Most people feel really sort of lousy, like the worst case of flu ever. And I was hospitalized for just those 3 days, from 5 to 8. But other than that, I was in a VRBO condo, and I stayed over at the hospital for a month, and I didn't feel great, but I didn't feel awful. And amazingly, I was able to go back to work 4 weeks later, only working 2 days a week, which is unusual. I did extremely well. And I would say that that's relatively unusual, but on this, I know a lot of people that had CAR T now, and I know people who are actually working 2 weeks after CAR T in the hospital. And then
Robyn, can I ask, after the stem cell transplant, how long were you out of work for, just for comparison?
I was out of work for 3 months. And when I went back to work, I was not able to eat solid food. I lived off smoothies. It was terrible.
Yeah, what a comparison. And I appreciate the follow-up from Dr. Brody about that comparison specifically, and also Robyn just pointing out that you had a really great response too. And we also know you said you're young, healthy, otherwise healthy, except for the lymphoma. So all these things may factor into a response.
Totally.
What you talked about just now actually does feed into one of the patient questions that was submitted from Gil R, which is, what are the pros and cons on or of CAR T cell therapy, and what is its duration? Now, Dr. Brody, I think you can answer this question several ways, but I think in talking about pros and cons, people do want to compare, right? Like, what are the side effects? And then in terms of duration, not sure, maybe we can answer both. How long is the therapy itself? And then how long is the expected duration of response?
Pros and cons very broadly. I mean, the pro, certainly if you compared it to what Dr. Stacey Humphries described as the old standard before that, the chemo and the stem cell transplant, the pro is that it is both more effective especially for some patients, and gentler. I mean, you heard that Robyn was out of work for 2 to 4 weeks, whereas after the transplant, she was out of work for months and months and only on smoothies. So you can hear right there, because when you ask doctors about efficacy, we can give you numbers, 40%, but when you ask about side effects, we kind of describe them in more nebulous, vague ways, because it's not clear which number to give. The number of percentage of people that get an infection, I mean, there's so many numbers you could give, but that is a great metric, a great number, just how long were you out of work for, or, just unable to do the things you do. If you're retired but you garden every day, how many weeks or months until you were gardening again? So yeah, I think that's a great example. So the pros compared to that old standard are better and gentler. But let's acknowledge the cons as well. And Robyn pointed at one, some of the side effects, and the most common and maybe one of the scariest ones is this CRS, cytokine release syndrome. And it's basically just like having an infection, but there's no infection there. You have fevers and sometimes very low blood pressure, dangerously low blood pressure. And even though Robyn was only hospitalized for a few days, I think the more common thing nowadays is folks are hospitalized for sometimes a couple of weeks on average. Sometimes it's a boring hospitalization, which is the best kind of hospitalization, but just to watch for that side effect to see if it occurs. Sometimes those folks have to go to the intensive care unit just to treat that low blood pressure and fever. So that is one of the biggest side effects. And then one other scary side effect is called ICANS, ACANS, but mostly we just call it neurotoxicity. Or encephalopathy. Mostly it just means there's a horrible problem with the brain, and this side effect manifests in many different ways, in hallucinations, loss of consciousness, all kinds of things. These things sound very scary, so I should first just preface it by saying there's kind of when we talk about duration, a defined time course to these side effects. They, as Robyn was saying, almost always happen within the first couple of weeks, just about always. There's a couple of rare exceptions, maybe happen on a third week, but they never happen, 2 months later. That's not a thing. So these are scary side effects, but they're sort of time limited for the majority of people, both the CRS and the neurotoxicity, but they're a serious big deal. And some patients have higher risk of those side effects, patients that are older or less healthy, for sure, and patients that have greater tumor bulk. Robyn was describing how many tumors she had in her neck then. Patients with enough lymphoma actually have more of those side effects than patients with just a smaller amount of lymphoma when they go into the CAR T therapy. So the pros are, this therapy has a greater track record of keeping people in remission, like Robyn, for years and years. We have some newer therapies that maybe are as promising, but they don't have the years and years of track record because they're newer therapies. And then the cons is these side effects are not nothing. And so if you were an 80-year-old patient with a bulky tumor, yeah, these cons are a serious thing, and we have to start thinking about other alternatives for those kinds of patients.
So Dr. Brody, let's talk about bispecific antibodies, which again, another very technical term. Some have described it very simplistically. Maybe the description would be more of an off-the-shelf CAR T option. And I think the larger theme here too that I've heard, and we get a lot of questions from patients and care partners about is, will I have greater access if I don't live near a great, large hospital or academic center with these bispecific antibodies? So Dr. Brody, what are they? And can you just talk also maybe loosely about some of the side effects?
Sure. Yeah, these are, I would say, the most exciting and transformational thing in lymphoma and DLBCL, certainly in the last couple of years, or maybe you might argue maybe ever, because their total impact they're going to have, my belief, in the next few years is going to be unparalleled. So bispecific antibody. So we talked about an antibody already. We talked about rituximab. So it's an antibody. What are antibodies? They're these magical little molecules, these big, long proteins that bind very specifically to one thing. And we make antibodies against COVID after we get a vaccine or get COVID, and a company can make antibodies against certain targets on lymphoma cells. So rituximab is an antibody against lymphoma, but it just binds lymphoma. So now some, I would say, brilliant pioneers from a few groups developed these bispecific antibodies. They bind two things. They bind lymphoma cells and they bind one of your immune cells, one of your T cells, the same T cells we were making CAR T cells out of before. They basically bind them. Some people use a Lady and the Tramp with one spaghetti noodle metaphor here. And if you haven't seen the movie, anyway, it brings them together. And except the only difference, instead of the kiss between the Lady and the Tramp, we say this gives the kiss of death, because the T cell kills that lymphoma cell, and it kills it pretty well, just like the CAR T cell that we were talking about before. So in a way, it is sort of an off-the-shelf version of a T cell therapy, like the CAR T cell. We're talking about some downsides of the CAR T cell. The practical downside, I mean, it's very cool that it's an individualized, you make the new medicine for each person. I send my T cells in, they send me back my CAR T cells. That's cool, but it's logistically, practically very difficult. So it takes a lot of time. How much time is a bit variable. It could take 2 or 3 weeks to make the product, but sometimes it takes a couple more weeks just to kind of plan the whole thing out. And sometimes it takes more weeks even just to get to see the doctor to plan that. So there can be real delays there, whereas these bispecific antibodies, you just inject it right into the patient, no delay there. So they are in some ways practically a lot easier because they are off the shelf. You don't have to make it for each person. And so the efficacy of them has been, I would say, overall awesome. They are not perfect, but they are putting a big proportion of patients into complete remission. And some of those patients are staying in complete remission for years. So that's fantastic. Maybe the numbers are a little less amazing than CAR T cells in efficacy, but they are also, as we're saying, a lot easier. And you're asking about possible side effects. Overall, they're a lot gentler. Those CAR T cells were causing sometimes the bad side effects, CRS or the neurotoxicity, in maybe 10 and 20% of patients, whereas these bispecifics causing those same side effects in maybe 1 to 3%, the bad version of those side effects, in maybe 1 to 3% of patients. So that already opens up a lot of opportunity, because some patient that maybe was not eligible for CAR T because it would have been too scary, maybe they could be eligible for bispecifics. And then also you're asking about just the kind of ease of access. Yeah, CAR T cells are available at a limited number of centers. That can be tricky, because you're not just going there for one day to get the therapy, you're there for a while, as Robyn was saying, and bispecifics should be available, maybe not today, because they were just FDA approved in June, basically, over the past couple of months, May and June. So they may not be available everywhere today, so we don't want to oversell that, but they can be available everywhere, and they're available at most major centers now today.
Right. And now that you're mentioning the two approvals that, again, yeah, very recent. So epcoritamab or Epkinly and glofitamab or Columvi, I hope I'm not butchering those, you know, they're newer, they're newly approved. It's great as new options just to share with patients, but how would someone know what questions to ask for, you know, whether they're, you know, a good candidate for bispecifics and or which option to go for? And you can also cover the fact that, as we know, it was approved for later lines of treatment. And even after approval, they're still in clinical trial because everyone likes to try and move it up earlier, right, in lines of treatment.
Yep. So yeah, very exciting. These two medicines were just FDA approved in the last couple of months, epcoritamab and glofitamab. There actually was one other that was approved for follicular lymphoma at the end of last year, which was mosunetuzumab. But just to point out that there's lots of these getting studied and approved now. There will be several more approved over the next year. And yes, they are approved as a sort of a plan C, third line therapy when plan A or plan B don't work well enough. So yeah, you know, if a patient asks the question, is this the right therapy for me? Tough and detailed question, but the first thing you want to make sure is that the doctor that you are working with is familiar with the option, because even though they are available anywhere, not every doctor can be. There's a lot of new cancer medicines coming out every month and year, a lot. And this is very tough, especially for community oncologists that take care of every kind of cancer, lung cancer, breast cancer, pancreas cancer. I mean, there's so many, so they can't, it would be impossible for them to be super familiar with every new medicine for every type of cancer. So it is not that every patient with lymphoma needs to be seen by a lymphoma specialist, but it may be common sense that once plan A and B have failed, this is not a great situation. And so now, let's just be simple about it. Bluntly, it is worth, in New York, what we call the schlep. It is worth the schlep to go and see a specialist who does nothing but take care of lymphoma patients, because they are familiar with these medicines, and it would be hard for most community oncologists to be familiar with them. Community oncologists will be familiar with these medicines over the next couple of years, but they may not be today, and they may not have access to administer them, because there can be complexity about getting these medicines started in a new practice. So yeah, are they right for me? You need to make sure that you're speaking with a doctor that has comfort around this. And a lot of times the community oncologists are vaguely aware of it, so they'll call their local buddy who's a specialist and say, you tell me, should I send this patient to you? But as you heard from Robyn, sometimes patients end up advocating for themselves. I'd like to say that there's a better way, but that does happen. And the function of Stephanie, of your group, and LLS and other patient advocacy groups is to try to be an intermediary, so patients don't have to advocate for themselves. But if you're asking the question, are bispecific antibodies right for me? There's a good chance the answer is yes. So yeah, you should at least be talking to someone that has experience with these. Yeah.
And when there are different options, Dr. Brody, and they're new, how do you make a decision on which option to put a patient on?
Stephanie, you told me when we set this up there would be no hard questions during the interview. So let me just say broadly that this is amazing. Although these medicines are newly approved, we've been using these medicines for a few years, 3 years, give or take. So we have a lot of familiarity with them. And maybe we didn't predict this, but the punchline was those two medicines, epcoritamab and glofitamab, in terms of the punchline, how effective they are, how safe they are more similar than different. They're incredibly similar. For example, like the complete remission rate for both of them was exactly 39%. What are the chances of that, of taking a 100-sided die and rolling and getting 39 twice? And also the side effects, those high-grade bad side effects were about 3% with both of those medicines. So the punchline is they are more similar than different. There are little nuanced differences, so I'll mention a couple of them. One of them is that the epcoritamab is given subcutaneously, just as a shot, whereas the glofitamab is given kind of the more conventional way, intravenously. So that's a little difference. It's not a huge big deal. And also sort of the timing of them is a bit different. The epcoritamab has sort of more visits and they might go on for longer. And the glofitamab maybe fewer visits and is designed, the recipe is for it to stop after about 9 months. So those are little nuanced differences. It doesn't give you an answer of which one is better. They're actually extremely similar. We do ultimately make a decision for each patient, but they're pretty similar overall.
Wonderful. One more question for you before I have another one for Robyn actually here, but let's bring back in CAR T. And I know that there are different approvals for, different groups of people, and there has to be that personal conversation between a patient and his or her provider to understand the best option. But generally speaking, if you're comparing CAR T cell therapy versus bispecifics in terms of limitations and challenges, what would that summary look like for our patient audience?
I hope it's okay. I'm going to change the question slightly. And here's the change, because the question is always which one's better, CAR T or bispecifics? But really, that's not actually the question people really care about, because unfortunately, because neither of these cure 100% of people, you as the patient, you kind of want to get access to both, not A or B. You might want both, this and that, or that and then this. So I think the best question is, what's the best order to give them? If you were going to get both, would you rather get CAR T and then bispecifics, or bispecifics and then CAR T? And sometimes it's a moot point, because CAR T are approved as a second-line therapy for some patients, and so far bispecifics are approved as a third-line therapy for patients. So maybe in some cases you don't have to make a choice, because this one's available, maybe that one's not. Although that's going to change a lot in the next couple of years. But I got to give you my honest belief about this. CAR T have one thing that is definitely better about them. They have a longer, kind of more tried and true precedent of keeping people like Dr. Stacey Humphries in remission for a long time. We just say curing patients. It's been proven for longer. So you may want, the most proven thing, and CAR T are that. They are the most proven thing. At the end, if you really want to get both, if you were to get a CAR T and then it were to fail, and ultimately it does still fail for a majority of patients, depending on the setting, if it cures 40, that means there's 60 that still we need to do better for. If it were to fail quickly, actually in that case, you might not be able to get bispecifics, because we mentioned the chemo you get right before the CAR T cells. That chemo might make the bispecifics not work well, because it sort of wipes out many of your own immune cells. So giving them in that order may not be great. So giving CAR T and just bispecifics right afterwards may not be a good option. Whereas if you were to give it in the other order, bispecifics first, and if you're in remission, great, you don't need something else. But if they stop working, then you could get CAR T afterwards, and we've done that many times now. So, it's not which one is better, it's what's the best order to get them if you're going to get both. And for some situations, it's going to be CAR T, but I think there are a lot of situations for which it would be you might want to get the bispecific first, also because it is gentler and the risk of those bad side effects is lower. Some people find that appealing as well. So there's no right answer, but I'm giving you a little bit about my sort of prejudicial belief about what might be the best order.
No, and I think sequencing is a huge question, and especially, if the bispecifics are approved for earlier lines, that it'll actually be a consideration for people. I think part of the question too was, all things considered, we did talk about accessibility a little bit. And so there's this idea that if it's off the shelf, that more people will have access to it, that, Robyn, back then I know you were one of the first, and so there were fewer maybe options for people anyway, and that was during the clinical trial phase. But in terms of, being able to travel somewhere to get the CAR T, well, I can't do that. So I'm hoping my community hematologist oncologist will be able to offer the bispecifics. Do you see any challenges there, though, even in the community with, bispecifics? And let's leave on a good note with this topic of what are some of the solutions.
So the bispecifics are gentler in that the risk of those high-grade side effects are less, but there is, I said, still maybe a 3% risk of those bad versions of the side effects. So as of today, folks getting bispecific still have to get hospitalized for at least 1 day, just to watch them on the 1 day they get the first high dose of that new medicine. That's not so bad. 1 day is less than a couple of weeks, but it's not nothing. So there still may be some community oncologists that may have difficulty getting that hospital bed lined up. It sounds like a simple thing, but practically it can still be difficult. So yeah, we are even trying to overcome that obstacle. One example is there's a new ongoing clinical trial of one of those medicines we mentioned, epcoritamab. We're trying to give it at a sort of a gentler step-up dosing so that you don't even have to get that 1 day hospitalization. And I think there's a good chance that trial will be successful, and maybe in the future you won't even have to get any hospitalization for the bispecifics. So we're looking forward to that. But as of now, yeah, that is a real thing. Even getting a 1 day hospitalization might make this be an obstacle to get this with your local oncologist, but hopefully that'll be solved with some of these new trials even over the next year or so.
Dr. Brody, there are, of course, lots of different clinical trials that are happening, that we haven't covered, but there are some, as great, I guess, as these developments are, everything has some limitations. And so there's always more clinical trials to try and solve those problems. If you could talk a little bit about some of the newer clinical trials that are happening and what problems they're trying to solve, especially in the bispecific space.
Yeah, absolutely. I mean, just very briefly, and this stuff is not super complicated. It's not rocket science. Those targets of the bispecifics, we talked about them a bit. So rituximab targets CD20, and these bispecifics mostly so far also target CD20, this marker that's on lymphoma cells. The CAR T cells mostly target another thing on lymphoma cells called CD19, and there's a few of those markers that you could maybe target. This is not so surprising, though. If you target something on the surface of those lymphoma cells, eventually, if there were just a couple of lymphoma cells that didn't have CD20 on them or CD19, those ones would not get targeted by the therapy, and they would sort of grow out and escape and cause the relapse. We call this antigen escape, when that targeted antigen, CD19, CD20, is lost by the cancer cells, and then those cancer cells grow back. And this is probably a main limitation of both CAR T cells and also bispecific antibodies. So there's lots of ways we could try to solve this problem, but maybe one of the simplest ones is we go after different targets. So we have now bispecifics targeting things that are not CD20, but targeting another antigen, another target on lymphoma cells called CD22. The numbers don't even matter that much. It's just going after something that wasn't, on the cancer cell initially. So they're still there even after the first bispecific didn't work. And then we have even things beyond bispecifics called trispecifics, going after two things on the lymphoma cell and then still getting the one thing from the T cell. So going after CD20 and CD79, and then grabbing still the T cell as well, the effector that's going to give the kiss of death to that lymphoma cell. And these are probably good ways to prevent this antigen escape problem. And we're just starting some of those trials now, but we've been treating a lot of people and we see patients going into complete remission. So maybe these will be even better than the already standard of care that was the cutting edge just a month ago, the new bispecific antibodies. Maybe we'll have trispecific antibodies as perhaps the new standard of care to prevent that problem. So yeah, some limitations, but already some solutions coming up for those limitations. So pretty encouraging.
This is all really wonderful to understand. The last section here is just humanizing clinical trials. So I'd like to bring Chrissy back into this. Chrissy, how can someone look up what clinical trials are out there on their own if that's the direction they'd like to go in? And this is, of course, where the LLS's Clinical Trial Support Center can help. Can you explain more about the numbers that you're seeing? I know there's a national enrollment for adult clinical trials that's very low, and what the LLS is trying to do to get the numbers up.
So many patients come to us having tried to look for clinical trials on their own, or a doctor told them to look for clinical trials, or they had a loved one who just, decided to start looking for clinical trials on their own. And they often come to us very overwhelmed, having tried to look at clinicaltrials.gov or other databases for clinical trials. And you can certainly go on to clinicaltrials.gov and look for trials yourself. But that's sort of what our department does, is takes that workload off of a patient and their families and does a clinical trial personalized search for the patients that we work with. And the national average of patients that participate in clinical trials is around 3 to 5%. So that's 3 to 5% of adult patients participate in clinical trials. of the patients that we work with at the Leukemia and Lymphoma Society, the patients that work with a nurse in the Clinical Trial Support Center. And we work to help them identify clinical trials that they're potentially eligible for, identify barriers that they may be facing to participation. Maybe that's logistical barriers, insurance barriers, just simply not knowing what options are available to them. And overcoming those barriers, our average of patients that participate is around 22%. So the patients that we work with have a higher chance of participating in clinical trials because of the work that we do to help them navigate the entire process.
Now we have a patient question from Joy B, who asks, are travel costs included for clinical trials?
Very good question. So around a quarter of clinical trials close because they don't reach accrual goals. So that means, they have a set goal for how many patients will participate in the trial and they don't reach it. And one of the reasons that that happens is that while clinical trials are at the academic sites, patients aren't always located near an academic site. So that means that they have to travel to participate in a clinical trial. So a lot of work has been done over the last 5 to 10 years to overcome that barrier for patients. If they have to travel to participate in a clinical trial, how do we decrease the burden for them with that travel? And that's been identified as financial assistance. So a lot of clinical trials will provide financial assistance to patients who participate in a trial that have to travel beyond a certain distance. Generally, it's more than 30 or so minutes. So if a patient has to travel more than 30 or so minutes to participate in a clinical trial, I highly, highly encourage them to ask the team at that treatment site, is there financial assistance to me to participate? And oftentimes there is. How it looks is different for every clinical trial and every site. Sometimes it is sort of a concierge service that, books patients travel or lodging for them. Sometimes it's a prepaid card that helps them pay for the hotel, the food, the gas, things like that. And other times, in not so ideal situations, it is done on a reimbursement basis where patients submit their mileage, submit their receipts for their food, and submit their receipts for their lodging, and then they're paid back by the company for those expenses. There's been a lot of advocacy from LLS and other groups to change that model because we work with a lot of patients who don't have the money to front that. If they can't pay for a hotel room up front, the reimbursement model doesn't work for them. Additionally, the Leukemia and Lymphoma Society has things like copay assistance, travel assistance that patients can apply for and potentially qualify for some financial assistance, whether that's to get treatment or to participate in a clinical trial.
Thank you so much for that, Chrissy. All right, we're at the last moment now here where we'd love to understand sort of the final takeaway from each of our panelists in terms of maybe the most important thing or just the one thing that they'd like for you to walk away from tonight with. So we'll start with you, Dr. Brody. What's your biggest message for our audience tonight?
Message is that patients with lymphoma are unlucky to have lymphoma, but so lucky to be here today with that lymphoma, whereas, 20 years ago, we didn't have nearly access to medicines that cure patients and keep them in long-term remission to go and live their lives, hopefully just like they were before. And we only have those new medicines because patients join clinical trials. So if patients join clinical trials today, they sometimes are getting access to the medicines of the future. These new bispecifics that just got FDA approved, our patients were getting access to them 3 years ago because they did this slightly scary thing and asked, hey, are there any clinical trials available? And for some of them, thank goodness, because they're still here to tell their story today.
I really want to tell people there are hope. Don't give up hope. Make sure you ask questions. Feel free to get other opinions. Really good doctors are not insulted when you get another opinion. Just take my word for it. And I just want to say I'm living a great life. I'm working, I'm traveling. I saw my youngest child get married. It's fantastic. But I think my message I tell people is that I've been a doctor for over 30 years, and I've taken care of a lot of patients. I've read hundreds of thousands of films. I've done thousands of biopsies. I've held a lot of people's hands. I've counseled a lot of people. But ironically, my biggest contribution to medicine is not as a doctor, but it's been as a patient. So grateful to be here. And thanks for everybody. And thanks, Stephanie, for doing this. This is fantastic. I wish I had had something like this when I was going through my experience. And thank you, Josh, for doing what you do.
Thank you so much, Robyn, to Dr. Robyn Stacey Humphreys, to Chrissy from the LLS, to Dr. Brody from Mount Sinai. Incredible discussion about clinical trials in the space of DLBCL. We hope that you're able to walk away tonight knowing more and feeling more comfortable with what clinical trials are. We want to thank also the LLS for all its great work that it does in blood cancers, and we'll drop a link to the Clinical Trial Support Center so it's easier for you to find. And finally, again, your voice is just so important. We really want to know what your feedback is from this event, from this program, and also what you'd like for us to cover next. So once this window closes, a survey will pop up, or a link to a survey. It'll only take a few minutes to fill out. And once you do, it'll automatically enter you into a raffle for a couple of our $50 Amazon gift cards as a small thank you for your time. So again, thank you so much for joining us. I'm Stephanie Trong with The Patient Story. We hope to see you at our next program. Take good care.